Some of the early manifestations are the expression of weakness and slow walking speed. Walking speed is one of the reasons why we have that. It's the sixth vital sign in our geriatric clinic, and then also decreased physical activity. These are all kinds of things that we want to gather either by directly asking the patient or by asking their spouse, caregiver, or family member. A lot of times we'll just get a little clue from family members. The daughter comes in with mom and says to you she's just not getting around as much as she used to. Maybe we need to evaluate for frailty. As we think about the differential diagnosis, all these symptomatologies can be related to other conditions besides frailty. We just can't say they're becoming frail or they're pre-frail. There might be issues with endocrine disorders, such as hypo or overactive thyroid. There might be some chronic inflammation where individuals get increasing inflammatory markers. Rising with their age, there may be issues related to organ failure, such as chronic kidney disease, progressing from stage 3 to stage 4, and accompanying that, elevated potassium, which causes further weakness or anemia. We need to think about the alignment of different diseases that may be associated. For instance, with weakness, there might be medication-induced myopathies. Anywhere for up to 10% of older adults on statins for hypercholesterolemia may experience some type of myositis or myopathy leading to weakness. Alternatively, they got started on amiodarone and they become hypothyroid. Because of it, they develop a muscle weakness. We always have to be fairly sharp on these questions. If we look at basic physiological methodology, starting with clinical presentation, we should look for possible decreased physical activity or the decreased ability to perform physical activities. These are all components of the frailty syndrome, and they lead to further physiologic dysregulation. Some changes at the very basic cellular and organ level. Some of the causes of primary frailty is the first point, inflammation. That's related to the steady increase in the cytokine called interleukin-6. Also, the inflammatory nonspecific, but inflammatory marker called C-reactive protein. You'll also see these rise during COVID and post-COVID. Both interleukin-6 and not so much C-reactive protein are associated and elevated with long-haul COVID syndrome. The frail older adult will have evidence of a decreased immune function that may be represented by a lower percentage of lymphocytes. They may be an e-MYC. They have an elevated hemoglobin A1C, and then other blood tests such as dehydroepiandrosterone and insulin growth factor are going to be decreased, leading to that increased diabetes-like situation, and there's other measurements. Their autonomic nervous system goes haywire, indicated by heart rate variability. Sedentariness can make a big difference. In terms of secondary frailty, the frailty phenotype occurs with untreated HIV and AIDS. Freddie Mercury became quite debilitated in his final years of life. Other conditions, such as heart failure, can cause a wasting syndrome, as well as chronic infections, like tuberculosis. All these lead to generalized weakness and frailty. Why would we screen patients for frailty? We want to identify the risk and hopefully prevent the progression. We want to do the assessment and gauge their severity so we can prevent or even treat the frail syndrome. If not, if it's untreatable, then to transition to palliative care. The best way to assess frailty is to use the Fried scale that talked about weakness, fatigue, ability, loss of grip strength, slowness, and slow gait speed. There's another one from St. Louis University called the Rapid Screening Frail Scale. The walking speed or grip strength are two clinic-based or physical performance measurements. Fried and Frail are staples, but 2024 brings digital dynamite. Apps with wearables nail gait speed remotely at 85% accuracy, no clinic trick needed. For your rural patients, it's a game changer, spotting pre-frailty via phone data. Tech isn't replacing us, it's extending our reach. The Frail scale. That's a mnemonic for fatigue problems, with resistance problems, with ambulation, illness, and weight loss. You can see, like the 5-point scale from the Fried scale, that if you have 3 or more of these checked off on your list, they would be considered frail. If they have 1 or 2, then that's considered pre-frail. Those are the ones that you really want to focus on for reversibility. Today's polling question is, according to the Frail scale, what does a score of 3 or higher indicate? A. Robust. B. Pre-frail. C. Frail. Or D. Secondary frailty. The correct answer is C. Frail. Here are some of the strategies for managing frailty. A comprehensive geriatric assessment is highly recommended. Sanford South Point in Fargo offers a comprehensive geriatric assessment, and they also have a falls prevention clinic. It's important to have a checklist of areas that can be addressed, such as polypharmacy. If somebody's on 5 or more medications, there's a 100% chance that they're having a drug interaction. Part of that could be a conduit to frailty. Unfortunately, many people are on multiple SSRIs and have loose bowels and malabsorption syndromes because they're on a bucket load of antidepressant medications that aren't of any benefit. The fall risk is important to measure. ADLs and IADLs are part of the functional status and also assessing their mood-sleep pattern. If you get less than 6.5 hours of sleep daily, you're at high risk for Alzheimer's disease. Looking at other metrics for managing frailty, if you have a clinical program and you have a panel of frail patients, focus on how well you are impacting frailty. Part of that's going to be measured by a reduction in nursing home admissions. We want to try to exclude secondary causes of frailty when faced with somebody that's either pre-frail or frail. Some examples are atrophic gastritis. It's possible to have a B12 folate deficiency because of atrophic gastritis. Those hypovitamintosis states was one of the reasons why they're having what they were in the pre-frail state. A lot of times unresolved grief, particularly during COVID, with loss of family members, can be an important consideration. You want to target the key components for trying to reverse or stabilize frailty by addressing physical activity, strength training, and nutritional interventions. Remembering that 1.2 to 1.5 grams of protein per kilogram is what's recommended for the older adult. The point of trying to minimize vulnerability through enhanced social support as much as possible, trying to avoid hospitalization. Sometimes these elective surgeries for an 85-year-old for shoulder surgery, it just doesn't make sense. That would be a way to prevent frailty, because assuredly, if that 80-some-year-old individual has shoulder surgery, they would have a high risk of not really gaining much benefit and being exposed to diseases, unsafe medications, and having a trajectory downward. Trying to balance relative risks and minimizing the vulnerability is really important. To minimize vulnerability, enter the geriatric triangle, frailty tangled with multimorbidity and polypharmacy, per 2025 proposals. It's a vicious loop. More meds worsen frailty, which amps up comorbidities. Break it with targeted deprescribing, trim one med at a time, and team huddles. If a patient on 8 pills drops to 5 and regains gait speed, that is proof this triangle yields positive results when untangled thoughtfully. With further strategies for managing frailty, we can look at the ADL-IADL support, such as Meals on Wheels, sometimes assisted living, or having a home companion. In Chicago, for example, at the University of Illinois Geriatrics, they have the Little Sisters and Brothers of the Elderly do home companionship. Personal trainers can be prescribed for older adults. It's sometimes a way to get social engagement. The other points are to look at converting people from a disabled state to an enabled state. It's a slow process, but it involves connecting with other individuals, community-based resources, and hopefully through some type of geriatric programming at the medical centers. Beyond ADLs like Meals on Wheels, 2024 shifts us to resilience. Think intrinsic capacity as your patient's superpower reserve. Instead of just compensating deficits, build on strengths. A quick app-based cognitive game or coping workshop can cut decline by a quarter. In my clinic, framing goals around what they can do turned a frail patient into a community volunteer. Resilience isn't a buzzword, it's actionable uplift. Let's talk about frailty prevention. This is to anticipate and avert these losses and physiologic reserves. Sedentariness is really the major cause of frailty. It's interesting, even at a biologic level, just sitting in a sedentary position causes for young people a contraction of their telomeres, which is the end parts of the chromosome that are kind of the pacemakers of the aging process. You can only imagine that with an older adult who's already got shortened telomeres, if they become sedentary and immobile, their basic cell mechanisms are starting to react to it and cause even further damage at the cell level. The other thing that you want to look at is be very mindful of depressive symptoms. A lot of times, these are associated with decreased physical activity. Ask your patients what they do when they get up in the morning. If you get a blank stare or an "I don't know," there's some issues that you will need to talk about in terms of healthcare goals and life goals. We've covered immobility and depression, but let's zoom in on social frailty, a hot topic in 2025 research. It's not just feeling lonely, it's a web of weak ties that doubles frailty odds by fueling isolation and inactivity. Screen with a quick UCLA loneliness question, then loop in family or apps for virtual check-ins. You can even make a simple weekly call to reverse pre-frailty in isolated patients. It's low-hanging fruit for prevention. With pharmacologic treatment, they've looked at an androgenic or adrenergic hormone replacement therapy and DHEA and so forth. None of those work. If anything, they make it worse. Some of the future treatments that they're looking at are addressing bioenergetics. Elysium is promoting a non-medication vitamin precursor supplement called nicotinamide ribose. It's kind of expensive. You have to take one pill twice a day. It's $60 for a 1-month supply, and it's kind of like a ramped-up vitamin B1 complex. It's been proven in research to be effective in animal models, but that's addressing the bioenergetics. We know that the nicotinamide that NAD cycle in with age declines substantially. The mitochondria within the cells, the energy producers, aren't able to really rev up the energy and the ATP that we need to get going. The other part of this is resistance training. It helps build those bioenergetic modules or mitochondria. By using resistance training, you help increase aerobic capacity and help address the whole question of weakness and low endurance. The question of anti-inflammatories is being tested as a frailty preventer. There's not a lot of evidence for frailty prevention, but it's a good idea to prescribe regular use of turmeric at 2 to 3 grams daily. That would represent an anti-inflammatory approach. Theoretically, that would fit the description of taking something that's anti-inflammatory. Finally, the concept of decreasing polypharmacy, with the reminder that when you have 5 or more medications, you have 100% certainty of drug interactions that could range anywhere from GI distress to sleep disorders to weakness. It's important for frailty prevention to not allow naps for more than 30 minutes a day if you're going to take a nap and maintain your physical activity. If you're watching TV during the day or night, stand up and sit down during the commercials. You need to do at least twice weekly resistance or strengthening exercises, and then also do some balance exercises, such as either Tai Chi or yoga. Bottom line is trying to prevent immobility. There's some interest in the Mediterranean diet. There are studies that show that it does lower the frailty risk, at least in one study. Protein. Micronutrient supplementation is always a good thought. There's a warning that sarcopenia occurs in obesity. Just because somebody has a high BMI or is a robust-looking individual, they can have very low muscle mass. They could be pre-frail by the definition. Looks can be deceiving. The bottom line is that in many studies, nutritional supplementation is only effective when added to some form of exercise. It's a multifactorial intervention or prevention plan. Let's talk about frailty and failure to thrive syndrome. Failure to thrive is a historic diagnosis when there is severe symptoms with no apparent cause. They just look like they have the dwindles is another way we called it. There's still controversy. Some people think we should just get rid of the term because it really doesn't have a particular mechanism behind it, and it just has some bad connotations. But the point is that there may be some overlap between frailty and the failure to thrive syndrome. The failure to thrive syndrome, you'll recognize that almost immediately. People are typically highly bedbound, just a wisp. They have temporal lobe, temporal atrophy, and skin thinning. So that would all be related to failure to thrive syndrome. Failure to thrive overlaps severe frailty, but fresh 2024 data sharpens urgency. 13.6% of pre-frail tip into full frailty yearly. That's why ditching FTT pushes proactive screening. Spot that wisp-like decline early with trends, not just snapshots. It reframes from pejorative label to preventable spiral. The transition to palliative care is something to consider. A lot of frailty scores of 4 to 5 coupled with either low cholesterol level or low albumin, those would be candidates for consideration for palliative care. Again, you can use those screening tools, either the Frail or the Fried Index. Somebody that has a gait speed of less than 0.4 meters per second would also fall in that category. Today, we're examining a case on pre-frailty in geriatrics, featuring Mrs. Elena Ramirez, a 72-year-old Hispanic woman presenting to her rural North Dakota primary care clinic after a minor home fall. She reports feeling worn out, tiring easily after tasks like grocery shopping. Her daughter notes reduced activity since her husband's COVID-19 death 2 years ago, plus 8-pound unintentional weight loss over 6 months despite stable appetite. Mrs. Ramirez lives alone, uses public transport, with a history of hypertension, hypercholesterolemia, on atorvastatin 40 mg daily, and CKD stage 3. She denies fever, chest pain, or dyspnea, but endorses low mood and stair-climbing difficulty. Vitals: blood pressure 142/78, heart rate is 82, regular, weight is 138 pounds, down from 146, BMI now 24.5 from 26.2. Exam: mild temporal wasting, grip strength 14 kilograms, below norms, gait speed 0.7 meters per second, timed up and go 12 seconds. Key history and risk factors: socially widowed with limited support, daughter visits weekly, lives 1 hour away, UCLA loneliness scale 8 out of 20 mild, sedentary more than 8 hours per day watching TV, no exercise. Meds: atorvastatin 40 mg, lisinopril 20 mg, metoprolol 50 mg twice daily, vitamin D 2000 international units, sertraline 50 mg, for grief depression, started 18 months ago. Comorbidities: controlled hypertension, hyperlipidemia, CKD stage 3, estimated glomerular filtration rate of 52, prediabetes, HbA1c 6.2%, mild anemia history, HbB 11.2 last year, functionally independent in ADLs, but needs IADL help, for example, heavy cleaning, no recent hospitalizations, avoided shoulder surgery due to recovery fears. Assessment: comprehensive geriatric assessment, CGA, per 2024 ICFSR guidelines for opportunistic screening in 65-year-olds and older, using Frail scale and Fried frailty phenotype. Frail: fatigue yes, resistance yes, stairs difficulty, ambulation no, illness no, weight loss yes, greater than 5%. Score 2 out of 5 equals pre-frail, high reversibility. Fried: unintentional weight loss yes, greater than 4.5 kilograms in 3 months. Exhaustion yes, weak grip yes, less than 20 kilograms. Slow gait yes, less than 0.8 meters per second. Low activity yes, less than 383 kilocalories per week. Phenotype: pre-frail, 3 out of 5. Additional: Labs show CRP 4.2 milligrams per liter, elevated inflammation, albumin 3.4 grams per deciliter, low, normal TSH, B12, folate, IL-6 is 15 picograms per milliliter, mildly elevated. MoCA 24/30, mild cognitive concerns, possible cognitive frailty per 2023 IAGG. Polypharmacy, 5 meds, high interaction risk. Differential, primary frailty, age-related inflammation, sedentariness, nutritional issues like low DHEAS or IGF-1 in prediabetes. Secondary, statin myopathy, 10% risk, unresolved grief and depression, social frailty, doubles odds per 2025 research, early CKD progression. Excluded, endocrine, normal TSH, infection, no fever, malignancy, recent screens normal. Management plan, multimodal, patient-centered per 2025 evidence for frailty reversal. For example, resistance training and nutrition yields 20 to 30% improvement. Deprescribing breaks polypharmacy frailty loop. Focus, exclude reversibles, optimize manifestations, minimize vulnerability. Pharmacologic and deprescribing. Trial hold atorvastatin, monitor lipids for 3 months, switch to ezetimibe if needed for myopathy. Titrate sertraline to 100 mg if mood persists, assess GI effects on weight. Add omega-3 2 grams per day, anti-inflammatory, reduces IL-6. Nutritional, counsel Mediterranean diet, lowers 6-year risk. 1.2 to 1.5 grams per kilogram protein daily, 70 to 85 grams, for example, yogurt, fish. Supplement protein shake, 20 grams twice daily, and micronutrients, B12 if gastritis risk, effective only with exercise. Refer to Meals on Wheels for social or nutritional support. Physical activity, home-based resistance, chair squats, wall push-ups, twice per week, 30 minutes, and balance, Tai Chi app, twice per week. Goal, gait more than 0.8 meters per second, track via wearable. Prescribed trainer, once a week, community center. Psychosocial, screen and treat social frailty with weekly virtual family check-ins and grief counseling. Resilience workshops reduce progression by 25%. Sleep hygiene, more than 6.5 hours per night. Monitoring, reassess frail and fried in 3 months. If the score is greater than or equal to 3 or albumin is less than 3.0, consider palliative. Falls clinic referral, avoid elective procedures. Follow-up at 3 months. Frail score 1, ambulation normalized. Gait 0.85 meters per second. Weight stable gained 2 pounds, CRP 2.1 milligrams per liter. Better mood, volunteer gardening via app, daily 20 minutes walks, grip 17 kilograms. No adverse events, lipids stable off statin. Daughter reports increased energy. This case shows pre-frailty as a vulnerable, reversible stage, 40 to 60% reversibility per fried updates. Early screening, for example, Frail in Clinic, identifies 6th vital sign, gait speed, to prevent falls, 5 times the risk in frail or nursing home admission. Multimodal approaches, exercise and protein, outperform singles, with 2025 evidence for tech in rural access. Rule out iatrogenic causes, for example, statins up to 10% mimic frailty first. In summary, frailty is a clinical syndrome that is associated with changes in bioenergetics. There are some clinical markers, such as inflammatory markers associated with it, that leads to a system-wide degradation of physiologic responses that occur both at the cellular and even molecular levels. The frailty indices, such as the Fried Index or the St. Louis Frail Index, account for these 5 parameters of weakness, slowness, low physical activity, low energy, and weight loss. Weight loss has been the least revealing or not revealing, but just at least likely to be part of these 5 factors. High risk of adverse clinical outcomes is associated with frailty, creating this spiral downwards of increasing fall rates on disability and dependency. We can understand frailty as that second point there as a continuum of severity. If you recall that Dalhousie's pictorial essay of frailty is a good conceptualization of early frailty, mid or intermediate, and then severe frailty. With prevention, the best prescription is not so much a walking mobility program, but rather a resistance training program. From there, going on to endurance and balance. The role of the Mediterranean diet is just generally good. There's some data that shows that even a pure vegetarian diet will improve frailty. As long as it has enough protein in it, it will vastly improve physical functionality as we age.